Hey, good morning, everyone. Welcome to Grand Rounds. Today, our speaker is Dr. Hilary Lum. The topic is Innovations in Dementia Caregiver Interventions. A couple of announcements before we do introductions and the presentation. The next Grand Rounds will be December 21st. We'll have Doctors Patricia and Harrison Bloom presenting on the Casoro Elders Project. Our next journal club is March 14th. Doctors Sarah Teets and Hilary Lum will be presenting articles at that journal club. One other special announcement, congratulations to Bennett Parnes and Maria Vahar on their induction in the inaugural cohort into the Clinical Excellence Society. Congratulations to you both. That's excellent. Excellent. Other announcements: following today's Grand Rounds, you'll receive an email with a link to the recording of today's presentation. Included in the email will be a link to an online evaluation. Please complete that if you don't have the evaluation in front of you here today in person. And please submit questions into the chat for after the lecture today. To introduce our speaker, Dr. Hilary Lum is a geriatrician and palliative care medicine physician who is passionate about designing, testing, and implementing pragmatic interventions for older adults with serious illnesses, including mild cognitive impairment and dementia, as well as their family care partners. She is Associate Professor of Medicine in the Division of Geriatric Medicine at the University of Colorado School of Medicine. She did her MD PhD at the University of Wisconsin-Madison, internal medicine residency at UPMC, and geriatric and palliative medicine fellowships at the University of Colorado. She provides primary care for older adults and their families of choice seeking to improve care and well-being for older adults with serious illnesses. Her research focuses on designing real-world interventions in partnership with older adults and care partners. Her work includes interventions related to advanced care planning, dyadic, triadic communication through use of the patient portal, and care for persons living with dementia and their family care partners. She is PI or site PI related to multiple clinical trials focusing on improving care for persons living with dementia. She was an inaugural NIA Impact Healthcare Systems Scholar awardee. Please give a welcome to Dr. Hilary Lum.
Great to be here. Let's see if this is on. I think it's on, kind of on. Not hearing me very well yet. Let's see here. I will go ahead and use this instead of this. And I am recovering from a non-COVID illness. I'm going to stand up here and take off my mask. Thank you all for joining me on a balmy December morning. Thanks to those of you who are online. My wishes for good health to the many of us who are not feeling our 100% best. Keep washing your hands. I'm excited to share about work that we're doing locally here to improve care, especially for individuals who support someone with cognitive impairment or dementia. I have no financial conflicts to disclose. The work that I'm presenting reflects some of our work funded by the National Institutes on Aging, Colorado Department for Public Health and Environment, and this is where I'll share information that hopefully is relevant to us as we share with other primary care colleagues. Funding from the Alzheimer's Association, American Academy of Family Physicians, and a PCORI grant through Ben C. Kluger. Our team is large, really engaged in dementia caregiver support. Many faces you may not recognize, but for those of you who are involved in Seniors Clinic, some of these individuals are our dementia care team navigators. Others are working behind the scenes in doing recruitment and engagement of older adults and their care partners in some of our clinical trials. Some are remote, some are here on the 7th and 8th floors, 8th floor, I guess. So we certainly know this, and it's in this context that dementia care is hard, that we then seek to do the best that we can related to supporting care partners, which of course involves identifying what's hard about dementia care and then how we might be able to intervene. So just as some introductory thoughts, we know that there may be very competing medical conditions that make it hard to prioritize how dementia may be affecting everything that we actually seek to partner with the individual and their care partner in developing a plan. We could build a great plan, but then with dementia in the mix, and if we don't prioritize it, that plan is a house of cards. Dementia can be hard to diagnose, especially in settings with limited resources, including time. As clinicians, we may experience limited knowledge of resources, including whether that's lack of confidence or comfort in diagnosing dementia, or then once dementia is diagnosed, what do we do? From both the patient and perhaps clinician perspective, there can be stigma, resistance, denial. That's a lot of what we face in clinic. All of this is time intensive, and all of it necessitates care partner engagement. I'm not going to focus on it, but probably 1/3 of older adults with cognitive impairment are what we would consider unbefriended. They actually don't have someone that they would identify as a trusted care partner or a network of care support. So now, with all of that context that dementia is hard, what would a dementia-friendly health system look like? I'll preface this by saying, I don't think that there's a clear answer yet. I don't have the answer yet. I'm very interested in engaging in any sorts of discussion of, could a dementia-friendly health care system look like this? Could we start with these types of interventions? Could we start to measure this type of quality care? So would love any follow-up as I continue to think through how could UC Health be a dementia-friendly health system. So some factors that I think would be part of it as we break down what would a dementia-friendly health system look like. Certainly it would be where, as primary preventative care efforts seek to care for our population, we would be able to focus on improving brain health and reducing dementia risk factors. I think many involved in our image group really are thinking about what happens in early life, midlife, what are those aspects of behavior change and exercise and healthy modified lifestyle factors that could really improve heart health, but also improve brain health. We'd like to increase early detection and diagnosis, improve quality of care, aligning with what matters, increase supportive engagement of family care partners, and increase connection to community resources. So this is my outline for today's talk. I'll break down each of these sections to share just an example of what we're doing here locally, which might stimulate conversation for what could we be doing next or better, and what else is happening around the country. Starting from sort of Colorado's perspective, wanted to highlight Colorado has a state plan for Alzheimer's. This is part of the national CDC BOLD plan for having every state have a state plan for our preventative health approach to reducing the risk of dementia among our population. Age is the #1 risk factor, and you can see where we are here in 2023. Currently, there are nearly 900,000 people over age 65, and 1% of them, 76,000, currently have Alzheimer's disease or a related dementia. So that's where we are now. In 2025, year or so from now, there is an estimated increase of 21%. We are one of the highest projected growing states in terms of new diagnoses of Alzheimer's, and that's also related to how our Colorado population is increasing in age, especially in the 65+ demographic. So we anticipate that more people will have Alzheimer's and related dementias in Colorado, and then in 2050, of our total population, we anticipate that nearly 2 million individuals will be older adults. So not 2 million people with Alzheimer's, but 2 million who are older adults, which we then, of course, know also means that there will be a number living with dementia. There are significant racial disparities in Alzheimer's and related dementia care. Wanted to highlight that nationally, people of color are 20% of the population of older adults. That is also increasing. By 2050, it will be nearly 42%. Then within specific populations, older Black adults are twice as likely to have Alzheimer's. Latino Americans are 1.5 times more likely to have Alzheimer's than non-Hispanic white Americans. And by 2060, the number of American Indian and Alaska Natives who are age 65 and older is also projected to grow, and especially those living with dementia. These data come from the center here on our campus. So these differences in risk are due to disparities from historic and ongoing marginalization, some of which include factors that are highly modifiable: education from very early ages, as well as other factors that I'll sort of highlight briefly. So as we think about clinically and as a society and community, what we want to invest in terms of risk factor reduction and public health campaigns, and then also interventions into clinic, really important to remember this context. November was National Family Caregivers Month. So this is my transition slide to say, as much as we are thinking about the individuals with dementia, we also recognize it affects whole families. President Biden said last year, during National Family Caregivers Month, we recognized the love and sacrifice of more than 50 million Americans, providing crucial care and medical assistance to parents, siblings, children, and other loved ones, ensuring their health and dignity. Likely all of us at some point have been, will be a family caregiver. So who are dementia care partners? You've maybe heard me said this name, care partners and caregivers. I'll use them somewhat interchangeably. In the literature is often caregivers. When we talk with individuals who are engaged in supporting someone who is living with dementia, they may often identify as a care partner. So that's where there's different words. These individuals are often informal, unpaid. There are terrific national reports about the numbers of care partners currently engaged in dementia care. Usually friends or family, may live locally or at a distance, as many of us clinically realize as we're coordinating care, may help in a variety of ways. Importantly, they may not identify as a care partner or a caregiver. So I think in the context we're in, whether research or clinical, I think there's so much value. As you name value, you see the important role that a care partner is playing. Driving someone to the visit, picking up the phone, providing translation, interpretation. They see themselves perhaps as just, of course, this is what I'll do. This is my role as a family member. And I think we can be really valuing them for their role as a care partner. This is my mom. COVID really unveiled her cognitive impairment, which is now at the level of sort of a mild to moderate dementia. I'm thankful that she's able to travel. So they actually arrived, my dad and mom arrived this Saturday. And I've seen my dad, as we've had many discussions in coaching, transition into taking on an additional hat of a care partner and caregiver role. So it is personal for many of us in the work that we do related to care partner support. Just a little bit about the health impacts of care partners and their experience. So when clinically we may diagnose someone with Alzheimer's, the average individual has then 4 to 8 years after diagnosis, although some may live 20 plus years. There can be quite a long number of years of longevity, even living with a diagnosis of Alzheimer's. And there are many excellent books written by people living with a diagnosis of Alzheimer's, and those are really insightful. So it can be a long illness, different than perhaps other serious illnesses. And as we know, individuals with dementia are likely to need help with daily care, likely to need a care partner. So in Colorado, there are currently 160,000 individuals who are caregivers. This is of all types and needs, not just specific to dementia. So a lot of caregivers. Carers report higher chronic conditions, depression, and financial strain. That data is specific to dementia. 1 in 3 caregivers for people with dementia said that their health has gotten worse in the past year. So this is really common. And we've then been thinking about a lot of different ways to support, and that's the focus of this talk. As I mentioned, we have our state plan. So for any of you who are health policy oriented or interested in learning more information, please scan this QR code. The Colorado State Plan has been working for several years now and is formally in our 5-year implementation period with goals of increasing public engagement, building policies and partnerships that help us to be a dementia-friendly state, assuring a competent workforce. So I think our university, we're excited about opportunities specifically related to the recently released HRSA grant for the Geriatric Workforce Enhancement Partnership. I think that's one major lever across the state for increasing dementia competencies across a workforce, which can include the caring workforce, sort of the frontline direct caregiver worker across multiple different sectors of healthcare. And then we also want to monitor and evaluate the quality of dementia care. So the state plan exists, and happy to have more conversation if anyone is interested. So now I'm going to sort of walk through some of the main aspects that we're trying to think about more locally as a learning health system, and also tools that we're trying to promote out to primary care and our colleagues who really see the bulk of individuals with dementia care. For us within geriatrics, we, as we know, are a scarce resource. And therefore, there's opportunities for us to be building educational systems and models that we hope are easily accessible to colleagues across the system and community. So just two slides on risk factor reduction, because most of my talk is focused on care partner engagement, but wanted to just sort of remind us of a frame that what's good for the heart is good for the brain as just a gross generalization, and that there are specific risk factors, many of which can be modified and improved to improve someone's risk of developing dementia. These are listed from a Lancet 2020 commission on what's the data for what risk factors can help reduce the risk of dementia. So happy to provide that citation, and it's in the module that I'm going to give you the QR code for. I think in clinic, we want to especially focus on addressing cardiovascular health, improving sleep quality and treating sleep disorders, encouraging healthy dietary patterns and cognitive stimulation. As we've heard in the past, social isolation is sort of an emerging risk factor, and loneliness for the risk of dementia. So I think we will see increasing evidence base to understand how might we also help with social isolation as a dementia risk factor. So that was obviously very brief overview, because now I'm going to shift to how can we, within primary care, be thinking about dementia diagnosis. This is very challenging for a number of reasons, and so just wanted to highlight that we have a few primary care pathways that are available. And Dr. Laura Mackey has been very helpful in leading this and gathering input from pharmacy, neurology, primary care, and geriatrics. And so here too, if you've had any experience using these and would like to provide feedback, please let me know, because we want to modify these so that they're as helpful to our primary care colleagues as they can be. So we have algorithms that start with clinical suspicion of memory loss, walking through elements of the history and physical, then recommending doing the mini cog, and that helps to have an algorithm toward normal aging, or if the mini cog is not normal, recommending a MoCA or a SLUMS, and then helping the primary care clinician think about more evaluation for, is this mild cognitive impairment or dementia? So we're building these to try to help reduce that gap of clinicians feeling a little bit overwhelmed and not sure where to start for evaluation and diagnosis. Then individuals, primary care clinicians, and others can use the dementia staging and management pathway, which is a separate pathway. Here, very interested in any input on this. So as you're thinking about staging, then we think about the many different categories that we're starting to try to build capacity for what does quality dementia care look like. Thinking about medications, patient and caregiver education, caregiver resources, safety, and care planning. There's obviously much more that could be put on this, but again, we're just trying to, for the busy clinician, provide them some help. We also want to emphasize that, of course, dementia is not just one experience for the individual. And so trying to equip a little bit with, are we more in early, middle, or late stages? Because that then has implications for pharmacologic management, also has implications for potential shared decision-making related to the anti-amyloid treatments. And then once you've done staging, we want to also provide information about potential pharmacology, and then potentially the guide model, which I'll share more about later. But for individuals with advanced or late stage, as well as actually early stage, the opportunity for a formal caregiver support program. So I know this was highly UC Health focused. There are also pathways that are very good and developed by the Alzheimer's Association, and I can point anyone to those who might be interested. So I wanted to share a little bit of the work that we've been doing as part of the state plan to try to encourage primary care clinicians to make more of the cognitive assessment within the annual wellness visit. The annual wellness visit does require an assessment of cognitive state. That's often by observation. The Medicare annual wellness visit actually doesn't require that you do an objective screening. We're trying to teach to use of the mini-cog and how we think it can be beneficial, and then next steps. So this was not necessarily designed for a geriatric audience, but I'd certainly appreciate feedback. And I know that UC Health this year, one of our clinical major emphases is on increasing the use and quality of the annual wellness visit, and that it's also an initiative that our pharmacists are leading within our clinic. I'm going to hope that this plays. Oh, with all of that build up. Okay, I will not worry about that. I will be happy to share the link, and anyone who logs in to the module can see it. Okay, this is essentially what the video walks through, is that we really do want to recommend that cognitive evaluation has a place within the annual wellness visit. There isn't a good way to actually understand the quality of cognitive assessment within the annual wellness visit. We all might be quite skeptical that any sort of quality cognitive assessment is happening in a robust way through the annual wellness visit. That said, I think that integrating in the mini-cog and a pathway for teams to be able to schedule for follow-up when the mini-cog is abnormal is really a key part, so that the screening doesn't just stop within the context of the annual wellness visit, but that clinics have a meaningful way of following up to assess function and recognize health disparities, and then really walk with the person who you've, for the perhaps first time, given them an opportunity to say, yeah, I have been having cognitive concerns. I actually am concerned about what's going on. So I think there are two key points here. We want to improve the sort of quality of cognitive assessment. Secondly, we don't want to do it so quickly, you get the process dialed in so well that we're actually missing the important counseling happening at the time of talking about cognitive impairment and cognitive changes. I've been alluding to this, so also encourage you to take a screenshot or scan the QR code. We have created a e-learning module designed for anyone who's interested in learning more about addressing risk factors, early diagnosis, and care planning for individuals who have dementia, especially within primary care spaces. So this was funded by the CDC through our state plan. You can also find it by going to cuelearning.org. You can find the dementia module, register with the code ADRD, which is not case sensitive. This is provides 2 CME credits, and it's certainly something we could discuss, whether this is like a flipped classroom opportunity for our internal medicine residents, and I hope to follow up with our family medicine residents to see if we could sort of incorporate in some accessible, I think, having been involved in developing it, 2-hour or less videos and content that helps hit the high points for how this could be better integrated into primary care. Okay, so now shifting to quality of care for dementia care. This is a sort of a transition into more of the research work that our team has been engaged in, and our general frame has really been from a community member and care partner and patient input perspective, really wanting to know their input on what resources, tips, tools, or programs would be helpful, knowing that there's this really confusing space of you're living with dementia and you really feel isolated and you're not sure where you can get help, and you may or may not trust your healthcare team to be able to be a source of help. And then trying to refine our systems and improve patient and care partner outcomes. So let's see if this video will work. This one may not either, which is okay. So the goal of the sort of 1-year opportunity I had as an impact collaboratory scholar was to focus on how our UC health system might be able to build tools and other functions behind the scenes that could help us make progress towards being a dementia health system where we might know who has dementia, sort of identifying them, being able to implement nudge interventions or other interventions that are minimal risk and could be implemented even as part of an adaptation of usual care, and then measure the quality of dementia care, including potentially after an intervention. So I'll walk you through some of our information, but as an overview, we've been focusing on the implementation of a dementia registry or algorithm. So we can identify individuals who have dementia across our health system. It's about 13,000 people. We can then identify how those individuals are engaged with the health system, and we've been especially focusing on patient portal use and shared access. I've told you about the primary care cognitive assessment pathways, and I'll highlight some next interventions related to our notes, which is very relevant to those of you in seniors clinic. And I'll also show you some of the progress we're making related to being able to measure dementia outcomes, which is difficult and an emerging field. So I mentioned that a lot of our work is related to engaging care partners. So as part of the Impact Collaboratory Award, we established what we called Memory Tech. The 18 members who volunteered to be part of this community patient and care partner council chose the name Memory Research Partners in Caring and Technology once we had met for a few times and sort of thought about what the content and discussion would be. They chose their name and met together over a 6-month period, 1 month apart. These are some of the activities that they did. We supported them with pre-meeting materials about the content of each discussion, sought to have interactive discussions about key topics such as digital health literacy, what a patient portal is, what the different types of dementia care are. That was supported by Dr. Samantha Holden, who is one of the collaborators. And then a ongoing discussion of what is it really like as you're trying to navigate care in a clinical care setting, perhaps through the patient portal and then also during the visit. What are the types of resources that you need? What are the challenges in communication that you're facing? So that was sort of a teaser about the content of our discussion. And then we also had post-meeting follow-up of with individuals and really sought to overall help increase their knowledge of how to be a research partner as we were thinking about the design of different tools to improve patient portal use in particular. So I share this in particular because while the Memory Tech Council is no longer meeting, they helped us with our adaptation for our notes. One highlight from this week is I found out that my K-24 has been funded, and the focus of that is, thank you. The focus of that 5-year mentorship award is on engaging individuals with dementia and their care partners in identifying really accessible and useful research methods for designing dementia care partner and other interventions. So another way to say that is we hope to establish a lived experience panel of individuals who are individuals with mild or early dementia and their care partners to be an ongoing campus resource for researchers, educators, individuals thinking about QI projects. If you want input from ultimately who you hope to be engaging in whatever you're designing, we will be meeting on an ongoing basis and would be happy to have you come and be a presenter to then get input on your whatever you're trying to design, and we'll have you come back. So the lived experience panel will be very similar to OVET, to the Accords group that is coordinated by Dan Matlock, similar to our Patient Family Advisory Council at UC Health. What will be specific is that this one will be focused on dementia interventions. So one of the things that I mentioned was focusing on identifying, let's see if I can make this go away, or at least come down here. So as part of the Impact Collaboratory Award, we did implement a dementia algorithm. So if anyone is interested, we are able to help you identify individuals with dementia that you could then look at their quality metrics or seek to intervene on them. Just as an overview of how this works in Seniors Clinic, overall, Seniors Clinic has about 4,200 patients with an average age of 82. 86% have an activated patient portal account. And then based on the dementia algorithm, approximately 600 have cognitive impairment of some sort. And again, this is going to be across a broad spectrum. I also wanted to, I highlighted that we are working on measurement. So I'm going to share just a little bit about this and the reality of, or the, some of the usefulness of you knowing about this is both for our clinical care, but also if you have care partners that may be interested in participating in this clinical study, which is open. We are calling it the Caregiver Voice Study. The Caregiver Voice Study is focused on optimizing two different measures. I'm showing one of them here, the Caregiver Rating of Dementia Care Quality. So to take a step back, we are all given opportunity to evaluate the quality of our oil change, the quality of our interaction, buying an airline ticket, et cetera, et cetera. We don't give individuals a chance to give us feedback on the quality of dementia care. So our hope is to have this questionnaire be something that can be in the context of a clinical relationship, be sent to the patient portal, to a care partner who can then give us feedback on what's the quality of dementia care. And this could be done annually. You'll see that the stem here is, we'd like to ask you about your experience. Can you tell us about it for the past year? This measure is part of Dr. David Rubin's large dementia care study, which has been expanded over 25 different sites. So the work that we're doing is validating it for use in a clinical study or clinical setting, not a research study, being administered by the patient portal. And I also hope that it's a meaningful tool that we can be using in quality improvement context. I'm really grateful to my UC Health partners. You can see from the screenshot, this is already available actually as a questionnaire that we can send through My Health Connection. And for those of you who have a good memory, a few years ago at American Geriatric Society, we presented some of our feasibility data of actually sending this to care partners. So I'm excited about our ability to potentially raise the awareness of caregivers and their perspectives on dementia care quality. It will help all of us be better as we have more opportunities for dialogue. And of course, this then means building clinic-based interventions and more resources to try to meet these gaps. in our current caregiver voice study, we are asking individuals who are care partners to complete these answers, and it's been really helpful to hear from them. I didn't even know that I should be expecting or asking a clinician to be sharing with me about what services are available related to dementia care. So in some ways, outcome measures can also be an intervention in themselves. So the caregiver voice study is currently ongoing. It's a telephone-based study. We're hoping to hear from about 200 care partners about the two measures that we hope are helpful in measuring dementia care quality in the context of clinical care. And then we're also doing interviews to understand more of the caregiver experience. This is just an overview of where we are in this process. So we're sort of here in stage 3 with My Health Connection, and many thanks to members of my team who are really excited about building outreach connections and doing presentations to caregiver support groups. And so one of the overarching goals of this study is to be able to build partnerships with our area agency on aging, with our libraries, with others who are directly supporting caregivers in community settings, and being able to give talks and build partnerships so that we can continue to provide integrated opportunities between clinical care and community settings. So this study actually provides an opportunity for us to do that a little bit. For those of you who are interested in sharing this, I'm happy to send you a research flyer, or you can look at the QR code here, which can be sent then to care partners of individuals with dementia if they're interested in participating. Okay, I'm losing my voice and I'm finishing up. So care partner support. This is going to relate to some things we're doing currently in seniors clinic. So I mentioned a little bit about our goals with the patient portal and thinking about how could the patient portal be more helpful in engaging care partners who are often the ones who are logging in through the portal, but who may not be known by the clinician. So we really think that we want to improve the caregiver's experience of communicating and coordinating health on behalf of someone with dementia. We think that the portal can help with that. And so one of the things that we've done is set up a pre-visit agenda setting questionnaire called Our Notes that then also has an additional question for the person who's actually filling it out to complete. So those of you in seniors clinic, maybe in May of last year, so it's now been running for about 1.5 years, may remember when you started to see the Our Notes responses coming in from patients having a new self-identification question. Which of these applies to you? And here's a schematic of what that looks like. We added the question, which of these applies to you? I'm the patient and someone's helping me. I'm not the patient. And that branched then to asking more about what is their name and their relationship. About a third of individuals have completed this, and I'll show you some of that data. We then kept the same 2 questions that are live across all of UC Health. So the self-identification question may be normal to us in seniors clinic. Know that this is actually only in seniors clinic. It's not something that's broad across all of UC Health. And one of the next steps that I'm working with CT Lynn on is there a particular patient population for which this question would be relevant to have live across UC Health? Including if it could be for patients with the dementia registry algorithm, or if it's live for people over age 75 or 80, or sort of where is that age cutoff where there's an increased likelihood that a care partner might be using the portal, but the clinician doesn't know about it. So we're really trying to help with that ambiguity where the initial note is inputted through the portal, and it's unclear who is sending it, whether it's the patient or the care partner. Sometimes you can tell, but a lot of the times you actually can't tell. So here's an evaluation of the pilot in seniors clinic. We looked in October 2022 at who was completing the notes. And you can see here that, as I mentioned, about a third of the time, someone completed our notes. So a lot of the times, as you all know, even though our notes is being sent ahead of time, someone doesn't complete it, and that's no problem. So a third of the time, 133 patients sent in our notes, and a third of those were someone helping the patient. So that's not surprising, but this is the first time we measured it. We know that there's a lot of care partner engagement in seniors clinic, and this is a way of having it be more concrete and explicit, because the clinician is able to tell now that it's an adult child, spouse, or other. And sometimes this was even a home health worker. And I'll just provide a caveat on that. There's a lot of discussion of whether, I think clinically, I would say, yes, let's have more engagement from home individuals, whoever can provide accurate input. Every state is different in terms of what the scope of practice is for home care workers. So even though we might want to really help increase the work and opportunity helpfulness that a home care worker could do, it may not even be within their scope of practice. So it may be sort of against the law for us to be asking them to do such a thing. So that's sort of a policy aspect as I think about designing interventions and who might be involved. Wanted to show you a little bit of information. So this data reflects the question of, do patients or others, when they're completing the pre-visit questionnaire, talk about different things? So we coded the different notes when free text was entered by whoever was completing the information. The green bars are when we knew it was identified as the patient. The blue are when someone identified as not the patient. And you can see that there's some variability in the types of questions or content that the two groups of people are discussing. No surprise here, the dementia-related concern, not brought up a lot by patients. These patients may be cognitively intact without any symptoms. And then 17% of the notes submitted by someone other than the patient actually had a dementia-related concern. Again, not surprising, though notable that the patient portal is perhaps often a way that care partners want to tell us information about dementia, and it can be important to figure out how then can we engage in communication, whether that's back through the portal, in the clinic visit, or separate in terms of what the communication dynamic is or needs to be when the patient and care partner are both as part of the visit. So I think that there are next steps in terms of even thinking about modifying the R notes further to identify, do care partners have any needs? So if a care partner has self-identified in our notes, one of our next thoughts is we could then ask them a brief questionnaire. Do you have any needs related to your role as a care partner? And then secondly, when care partners are talking about questions related to the person that they're supporting, we could even ask the question of, would you like us to talk about this in the visit, or would you like us to talk about it separately? And thank you to those of you who participated in clinician interviews and gave us feedback. That was one of the aspects of how to adapt our notes, thinking about, could our notes even help us make a next step of the communication preference and help to sort of give us some direction of what would be okay with the care partner so that then the clinician could follow up appropriately. Let me move this down here. I don't know how to make that go away. So from a research perspective, as we think about our notes as an intervention, we're trying to think about how might our notes fit into a work system our health system that has different technology and tools, including a pre-visit questionnaire, has different people who have different needs, skills, and values, the patient, the care partner, and members of the care team. We have our specific environment, which is really high functioning, and yet how could we also design for other environments that may not have the same resources that we have? And then what's the specific task or intervention that we're currently designing? So in this case, it's the pre-visit questionnaire with a new self-identification question. That then influences a work process, which I've sort of alluded to. We hope that this helps with accurate communication, shared knowledge, and goals. And then we next will desire to measure outcomes at the level of patient, care partner, and clinician. Does this help with clinician efficiency? Does this help with dementia quality of care by helping us to have a shared agenda, perhaps? So also as we think about, there, we'll put it up here. So now I'm going to zoom back out a little bit. I've told you a little bit about our Notes project here for care partners, but I've been sort of alluding to what might we be able to do within the patient portal ecosystem, or more broadly within a health system that has health information tools like Livy, our chatbot, other interventions, which I'll talk about. So thinking about like what might be some of the interventions that we can design, moving from what's already typical clinical care, though perhaps we aren't doing it enough, to aspirational. So shared access is something that certainly exists, and we should promote, which is where a care partner registers specifically for their own account. That would obviously help with confusion, because if a care partner is using their own account, you know that it's the care partner sharing the information. Then I talked about our Notes, where there can be patient and care partner generated content coming into the clinic visit. And we're trying to highlight how that might help us to identify dementia caregiver needs. We also have grants under review where we're trying to think about messages that come in through the patient portal being read through natural language processing for the 4 M's. So thinking about, can a natural language processing algorithm look for concerns with falls / mobility, mentation, dementia concerns, what matters, thinking about even if a care partner is involved, and sort of starting to think about advanced care planning, and then also medications, and even thinking about deprescribing. So I'm part of a national work group that's been thinking about, are there different ways that we could build behind the scenes tools that could support identification of dementia specific or older adult with chronic condition specific issues that then could provide resources or referrals related to helping with those needs. It was very interesting to hear last week that actually today, December 5th, the AI generated notes have gone live. So I am interested in what our experience with that will be. So for those of you who have not heard, in seniors clinic, but I think also across other clinics, I don't know if it's across the whole system, when patients or care partners submit a patient portal message that is non-urgent, there is an AI process that will auto-populate a note that then the clinician can choose to use or reject and write your own message, but use and potentially adapt and then send back to the patient. At the very bottom of that message, there is an additional note that says, this note was auto-generated and adapted by Dr. So-and-so. So there's transparency that the note could have been completely auto-generated. And that provides us next opportunities to really understand how this is working in seniors clinic. So I followed up with Sarah, and I have a meeting with Dr. Eden English to really do an evaluation of, in seniors clinic, how well are we using it? Do we choose to use it? Do we choose to discard it? So that's one question. when we choose to use it, is it giving us information related to the 4Ms? Like, how well does the AI generated note provide responses that would be in line with geriatric syndromes and potential resources in the community? So things are moving relatively fast and relatively slow, depending on how you look at it. Okay, so finally, from a community resource perspective, just one example of some of the things we've been working on. We are looking to collect resources and make them more accessible, especially to Latino, Hispanic, Spanish-speaking caregivers of persons with dementia. This is related to Dr. Laura Hansen's inpatient study that we are a site for, where we are enrolling individuals with advanced dementia and their care partners during a hospital stay. They're randomized to either palliative care or usual care. And one of the key points of emphasis is transitions of care support and caregiver resources. We have a supplement to be able to expand this to individuals who identify as Hispanic. And so we've done a lot of cultural adaptation. And this resource guide is one example of that. So for any who are interested in this guide or input, welcome your input. Thais, one of our incoming fellows, has been key in helping develop this. Okay, so a little just finishing up with some of the qualitative work that she did, as well as with Ellie Cranky, a second-year resident interested in geriatrics. They interviewed some of our Latino caregivers and identified that there's really still a clear sense of challenge and lack of resources for these caregivers. Finally, another resource that we are developing, Livy is our chatbot within UC Health, and we have developed what's considered a memory skill. So if you go to uchealth.org and hover over Livy and type in, I have questions about memory, or I'm interested in information about dementia, we've programmed in a set of evidence-based resources tailored somewhat to Colorado, and then also linking to national resources that we find are reputable. And I'm showing a screenshot here of how individuals could learn more. I think Livy is going to be an exciting opportunity because the functions are rapidly evolving. Individuals could say, I'd like follow-up related to a dementia concern, and I believe that that can now be sent to a clinical pool. So some of the challenges with chatbots, in my perspective, have been that it's just been sort of disconnected from a clinical entity. And I think UC Health is building in more opportunities for there to be opportunity for clinical follow-up. From an educational perspective, not from a specific clinical care of that individual. Wanted to then just spend a couple slides highlighting the guide model. So the guide model is the first time Medicare is going to reimburse individuals for care partner support. It's like groundbreaking. The VA has done it for years, and I'm very excited that CMS now is launching an 8-year pilot. Applications are open until the end of January, and I'm working with CU Medicine, hoping that we will be able to be a site. We don't know if we'll be able to yet, but I think what this would enable us to do is continue the Living with Dementia program, which is now part of the Care Ecosystem Study. And my hope is that we'd then be able to offer the guide model to individuals with dementia and their care partners. All of these models have in common a trained care team navigator who does monthly outreach and educational engagement with care partners, meeting, assessing what's challenging for them and providing education related to the evolving needs of supporting someone with dementia. There's also a pharmacy or a medication review and connection to social work resources. So I think whether you call it care ecosystem or D-care, or the Healthy Brain Clinic model out of Indiana. I think that there are excellent models of collaborative care, which finally will have the opportunity to be supported through the CMS guide model. I'm highlighting in red from our dementia algorithm, and these numbers are being confirmed by CU Medicine, the numbers of individuals with dementia who probably would be eligible for the guide model. So you can see that, you know, there are certainly individuals with dementia that we think that we would be able to support. So we'll see if this is something that we're able to be accepted into the program. A little bit more on the guide model. Pretty typical. I think the nuance that we need to really be thinking about for now is that it's only traditional Medicare fee-for-service. So this means that it would not be available to Medicare Advantage. Okay, so with that, this is back to my overview slide, and I will pull up the chat and happy to take questions. Appreciate your attention and Carrie.
So thank you so much, and thank you for doing this for your mouth. Well, the thing I keep thinking about is the 40% older adults who have a smartphone and unfriended, and people who couldn't bear to mention it because they might have sent their spouse, and I don't want to know if there's a diagnosis. And I see patient portal, Libby, all these things that require high tech skills. And I'm wondering what's coming up about. I love the navigator idea because it's outreaching, you know, phone call, low tech. And I almost want to see the pyramid flipped, where the aspirational one is the one we're actually starting with, where we hear from families about, here's what I'm worried about. It gets all AI translated, and then we hear that as opposed to forcing people to know tech.
Yeah, thanks. For those on Zoom, Carrie asked or made the reflection that there are still, even as technology literacy is increasing, there's truly still the vast majority of older adults will not be reached by many of the tech-related interventions. So what else is happening that we can be focusing on? And I very much agree with you. And I think that is why it is, I guess I also say, like, circling back, dementia care is hard. Is sort of like that. I think that reality is important for me to remember, and is something that I experience as a care partner, and then as a friend who perhaps others of you have experienced this too. You know, you get texted by friends who are just really in the struggle of dementia caregiving, and how even having a loved one be willing to engage with a healthcare provider because of the stigma or because of whatever barriers are there. Yes, there's like the needs related to dementia are hard. So I think then starting there, that motivates me to really be consistent and rigorous about stakeholder engagement and patient and care partner engagement continually, so that we can be hopefully developing really diversified interventions, because I do think are different interventions that are going to be valuable to different populations. That I think also is why I'm very excited that on March 8th, I'll just put a shout out, Dr. Ann Basting will be our visiting professor. She's really thought a lot about social prescribing and how more of our community-based opportunities for caring for individuals for dementia, really, like, our efforts should be in the community. So thinking about memory cafes, thinking about really robust partnerships with many of the frontline aging service network organizations who are really seeing individuals in their homes or close to their homes through Meals on Wheels or senior day centers. Yes, so both and yeah, I agree. Lauren, and then I'll come back to chat. Yeah, thanks, Lauren, for chat. The question is, are there any opportunities to do better at linking the needs of care partners and recognizing the needs of care partners in the context of the EHR? Because care partners often have their own health needs, as is clearly documented. I think that there's lots of need and opportunity for policy change in this space. Right now, it feels like there are quite significant barriers in those linkages. I do think that some investigators, especially within, I've heard of examples within Kaiser's system where it's a little bit easier to sort of develop the family or the same address cohort to do a little bit better job about caring for a linked number of people. We heard from Jenny Ports as she was thinking about the social convoy and gathering the community of care partners, though that's still around the person with dementia, not necessarily identifying well the needs of the care partner. So your point is very well taken. There's a separate body of research that really is caregiver focused, but less dyadic. So there are lots of interventions to care for care partners, but you're right, it's still separate from their role in caring for someone with a serious illness. Let me take a look at chat. Thanks, Abby. Wondering who is studying the patient care partner perspectives or reaction to AI messaging, seeing the value in terms of reducing burden on care teams, but I wonder about losing the human aspect of care, and it's a delicate balance. Great point. We will be able to at least understand that in seniors clinic because we are having live the AI generated messages. I will work with Dr. English and we'll develop an IRB to be able to then interview many of our patient and care partners who may have received a response AI generated from one of us in seniors clinic. So yes, we will be able to look at patient and care partner perspectives. Thank you. I ran us over. Bye.